good afternoon. Welcome to the Schulich Executive Education Centre Leadership Lessons in Troubled Times. We're joined today by Dr. Kevin Smith. We'll have him shortly join us. Before we get started with Dr. Smith, I wanted to quickly give you an update on the list of speakers we have coming up. We have 8 great speakers, including Walmart, Toyota, we have Linda Lundstrom, and Deloitte. We also have coming up next month, General Andrew Leslie. We have Sunnybrook's Rue Tagger, Anita Swamy, and David Garofalo. Before I get started, I wanted to just again quickly introduce today's speaker. Dr. Kevin Smith is the president and CEO of the University Health Network. UHN is Canada's largest academic health sciences center and ranked in the top 10 hospitals worldwide by Newsweek. Dr. Smith will be interviewed by my colleague, Alan Middleton, who is the executive director at the Schulich Executive Education Centre. And like all previous sessions, if you have any questions, please feel free to use the chat function at the bottom of your screen. We'll also be recording today's session for our video library. Now, I'd like to hand over to my colleague, Alan Middleton, to get us started. Alan?
Hi there, everybody. I'm not sure whether Kevin's joined us or not yet.
I am here. Alan, can you hear me?
Hey, we can hear you. We can't see you.
You can't see me. I'm trying to figure out how to do that. So bear with me. But you go ahead.
Okay, let's go ahead. So a big welcome to Kevin. As a lot of you know, UHN, as Robert's mentioned, is one of the largest and certainly the most highly regarded of healthcare groups in the world. And he's been on the front line with his colleagues facing this. So we'll start off talking a little bit about what's going on that front now, and then we'll move to hopefully talk about the recovery and some of the leadership lessons from there on out. So Kevin, how are things? How do you see things right now?
It's not it's not the usual time, shall we say.
Yeah.
It's unusual times for healthcare. The last 10 weeks, on the good side, we've had things go, some things that have taken years to get places have come, really far in 10 weeks. So as an example, I'll say virtual care.
Yeah.
So we muddled along with virtual care for a very long time. And all of a sudden, when patients couldn't come to see us and we couldn't actually get out to see them, we figured out some things with virtual care that probably would have taken us years and much negotiation. It happened overnight. On the other end, COVID has been very scary, not only for those who in the general public, but for those in healthcare. Not unlike SARS and some other difficult, challenging times. Here we've been with people who are coming to work and fundamentally not knowing really how dangerous it was. And that's scary, of course, for all of us. So I think the biggest issue has been, how does one deal with the unknown? That isn't unique to healthcare, but our healthcare providers have been very, very close to this one. And so I think fear is an unusual motivator and a challenging one at this time. So we are now working through that. That having been said, I think Canada did reasonably well on the community-based outbreak. And obviously our challenge has been in long-term care, where over 80% has happened. And all of you, I'm sure, will have seen in the last few days the very disturbing report from the Canadian Armed Forces, which I hope will precipitate a revolution in how we deliver long-term care. We've known this for some 30 years. But as always, healthcare people thrive in an environment of urgency. So they've done that very, very well. I think the challenge is now, what does the new normal look like? How do you get back to things like efficiently operating, not unlike many of your colleagues on the line today, just crazy stuff. Like, we have large buildings and 30,000 people in them every day. How will they get on elevators and get to the place they need to go? What time should they come to work? Who needs to come to work in the future or should continue to work from home? All of those questions that aren't unique to us, but are certainly very, very important as we start thinking about what the new world order looks like. And then, of course, in the middle of all that, this is bidirectional. If we see COVID go back up, then we'll also have to turn down our other hospital-based activity. And obviously that's a bit anxiety provoking for many of our colleagues, which one could quite literally understand and appreciate.
Yeah. Kevin, we're getting lots of chat people who say they want to see you.
I know, I'm trying, you know what,
everybody don't worry. He's okay, he's good looking, he is really there. So we're trying to get it fixed up, but we'll go ahead anyway. Kevin, one of the things you and I talked about before as part of the recovery is that it's now so segmented. So we had an interesting issue yesterday where the city of Toronto published the list of COVID by postal code. And of course, one of the challenges with a province as big as Ontario or Quebec is how do you manage that process? And you and I talked about, not surprising given the concentration of population, maybe the GTA and Montreal City, like Calgary recently, have to be treated slightly differently. How do you think about that?
Yeah, I think it very much has to be treated differently. I mean, as I said, it is now a Montreal and Toronto disease. And, you know, I think for many of us, we're trying to understand why we would need to really treat all of Canada in the same way, where clearly that is not the issue. You know what, if you're in Kingston at the moment, there are no cases of COVID. And now the worry, of course, is one has to be vigilant and not end up in an environment where you could see some people from Toronto or Montreal enter Kingston and then sadly end up starting an outbreak there. So clearly we have to be mindful, but I think it's going to be very different in the GTA and Montreal than it needs to be elsewhere. That also comes with some downsides. So as an example, in restarting scheduled care, Kingston is ready to go. I think it'll be some period of time before places like University Health Network and other large Toronto hospitals have the capacity to get going. So I think that one is worrisome to me, because when it comes to an equity of people who've been waiting for things like cancer care, as an example, they are anxious to get their care done. We're anxious to help them get that care done. And I think the sooner we can get that done, the better. It's very anxiety provoking for someone to tell you at the beginning of COVID, you have an oncology problem. And by the way, stay tuned. We'll get to you as soon as we can. That's not very encouraging for patients, and certainly not very encouraging for providers who are attempting to provide those patients the kind of supports they need.
One of the things other speakers have talked about, and you and I have talked about, is part of Canada's response, if I can call Canada as a singular response, which it isn't, but you get the idea, has been a breaking down a bit of the silos of communication between government, between the healthcare operators, between the drug companies, between various people. And that may have been behind part of our rather better response than our friends down south. Can we continue that so that we lean across the silos and learn from each other?
Oh, I think unquestionably. And one of the strengths in academic medicine, or anything academic, is the nature of academic work is we do share things. So that is our norm, not our exception. And I think increasingly, particularly now, I've never seen a time where we've had more things happen more quickly and people collaborate more openly. So science being a very interesting and challenging group of disciplines, never in the history of the world have literally the world's scientists all been united on a single theme, which they are at the moment, and that is ending COVID disease. It is why many of us are optimistic, if not a vaccine quickly, then at a minimum a antibody that could be developed and see a much less severe illness and much less life-threatening illness if humanly possible. So I think collaboration is what it's going to be all about going forward as well. I think we also know that there are many environments now where I think many individuals have decided that it is an opportunity for us to revisit some of the issues like social distancing as it relates to poverty. When we look at the most disadvantaged, it's those living in congregate settings. When we look at what happened yesterday when the Mayor of Toronto released their data on high impact neighborhoods, there were really two defining characteristics. One, you're elderly, and the other, you're disadvantaged, or you live in poverty or near poverty. And so, and often, and when those two come together, even more challenging, when elderly and living in deprived neighborhoods, then we know you're most at risk. So we've all talked about the social determinants of health for a very, very long time. I think now the much more than the talk will be the action of how do you translate that into.
Absolutely. And one other thing that we chatted about before is how do we balance the need to move fast ahead, but be careful of two areas. One of the things talked about is let's get rid of some of the unnecessary red tape in these processes that you talked about. But in addition to that, how do we still make sure that we're dotting the I's and crossing the T's on the research?
Yeah, it's a great question. We had a bit of a discussion earlier today, and most of our focus was really on what came out of COVID that's been good.
Yeah.
And the rapidity of decision making was at the top of the list.
Yeah.
The risk avoidance was marginalized considerably. That people were much more risk tolerant because they had to be. Issues that would have taken months or years with legal affairs or intergovernmental affairs or process issues in terms of the normal bureaucratic process, checks and balances, it really completely has shifted, and in a good way most of the time. So I think that increasingly we will all be going back and asking the question, what could we do to keep some of those initiatives? And what I realize, some of it's unrealistic. Government isn't forever going to feel comfortable without legal checks and balances that they're used to. But I think there is an awful lot, for example, the relationship between long-term care facilities and hospitals. That at the moment, hospitals have been asked to lend a significant hand, and we're pleased to do so. These are shared patients. If they can't be cared for in long-term care, they will need to be cared for in a hospital environment. So I think the future really does need to look at how could we continue to do that kind of work for the betterment of two aims. One, better quality of care and quality of life for residents, and equally importantly, better quality of work life for a often frustrated staff.
Absolutely. We have a series of new checks and balances that we need to get to. Again, you have a concern of, we need lots of data, but at what stage does protection for health overcome the issues of privacy? And, we looking at that coming ahead for much more complex decision making.
Yeah, you know what? It's been very interesting. I think I've never had or heard a patient or consumer say, I don't want you to share information with people who are caring for me appropriately. What they do say is, I don't particularly want a commercial enterprise to do so. I don't want someone making money off of this. I'm more than happy that the hospital or healthcare region is using that data in an anonymized fashion to improve the experience for others. But what I really don't feel comfortable with is not knowing how you're going to use the data. But if the data is in the betterment of my care or in the betterment of others who have similar challenges, then I think they're, for the most part, more than willing to consider those options and make that available. I know that'll be a challenge, more challenging as it comes to working with our colleagues in privacy. And one of the other challenges we face is this is both federal and jurisdictional from the perspective of the province. So I think that one we're going to have to get more right as we go along. But I really think that one of the most exciting things to me that's come out of COVID is the opportunity for truly global data sharing. And when you think about this disease and a whole bunch of others, when you put all of the data together, the power that that unlocks for so many sectors, really quite remarkable. And I hope we're able to navigate our way through
Excellent.
that. I know it'll have its challenges, but I hope we can.
And it reinforces what you said earlier about not only having it, but sharing it to work on it in a more collaborative way across borders, across the silos. Can you talk a little bit about, before we move on to more to the future in general, how your staff have been responding to this? We know they've been absolutely spectacular, but there must be where in 3 months, we've got 3 or 4 months at least probably to go. How do you manage the burnout issue? Because there's enormous pressure on nursing staff, physicians, as well as all the managers and administrative staff. Kevin, we can see you.
I think you can see me now. I have to figure out how to disconnect you from one other text.
Everybody hold on. We will get to see him as well as listen to him. The new one is muted right now, Kevin. So we need to get off the mute. There we go. All right, it's good to see you.
Sorry about that.
I told everybody you were good looking, so now they can see it.
I'm a fit for radio, as they say,
Yeah,
right?
excellent. So, question about the staff, both of the nursing, the physicians, and the general admin staff.
Yeah, so I think that we are all anticipating a significant post-traumatic stress syndrome letdown of this illness. I think the other piece is people have really been working full out, and particularly those closest to COVID positive patients. But in addition to that, I think it's not like we're going to get over this and there'll be this wonderful lag, because in healthcare, we've canceled in Ontario 100,000%.
Wow.
So we need a catch up, and that means working at 120, 140, or 160% capacity pre-COVID. So not only are we going to have to do more, we're going to have to do more extremely efficiently. And I think all of us are anxious about what that economic picture might look like in the shorter and longer term. I think we've done a much better job than historically in healthcare around putting mental health on the front burner. We're talking about it. We're watching our colleagues. We're talking to our colleagues. We're reaching out when we see behaviors that could indicate either stress or responses that would suggest people in crisis. Our EAP programs are stronger. Our promotion and support, the Ontario Medical Association, the Nursing Association, all have much, much, much better programming. And I think, mental health is a disease whose time has come. You'll hear CAMH's logo being mental health is health. And I think to a large degree, we're recognizing that the split of brain and body, or mind and body, is a very artificial split, and that most biological diseases have a psychological component to them. So forget about COVID. If you have a heart attack and you're depressed, which often occurs post-infarct, you have a 4-time greater probability of mortality, of dying, than if you're not depressed after your heart attack. So I think many of us believe the entire behavioral health paradigm needs to permeate every illness and every discipline. Princess Margaret is one of the institutions that's part of the University Health Network. I can't imagine that you would have cancer and be involved in a comprehensive cancer trial, for example, and for us not to believe that there should be a behavioral component of health considered with that. Similarly, I think in this case, it'll be both for patient, but now also for provider.
Yeah. It's a slightly odd question. I'll burble for a little bit. You're trying to think about it. Outside the healthcare sector, you think about the commercial sector, you think about government, you think about all the other sectors. What should they be doing to improve the mental health and pay attention to the physical health of their employees? Because right now, to be blunt, we expect our healthcare system to pick up all the pieces. We send people, I'm sorry, but less through GPs and straight into emergency rooms and things like this. That strikes me as a pressure that's got to change, and the rest of us have to take on more responsibility. How would you respond to that?
Yeah, you know what? I think it is one of those environments of how do you engage and involve people so they wish to take part? And, I think the old adage, meetings will continue till morale improves, just doesn't work. We all know what we should do to improve our health. It's doing it that seems particularly challenging. Doing it in an environment where we know that stress, which is a particular component to behavioral well-being and physical well-being, is challenging down to the biochemical level of cortisol production. So I think that more and more employers are attuning to the health and well-being of employees. I think the smartest companies are recognizing that it goes directly to the bottom line. So when you think about sick time, and when you think about mental health as a particular component of sick time, if you don't believe that this is the right thing to do morally and from a justice, equity, and quality perspective, think about 10 lost days per year of productivity in your sector because of mental health issues. Add to that other physical challenges and burdens. Is there a good way for that to be comprehensively translated into the public? I think North America has probably done this less well than many. And this is not a political statement, so forgive me, I'm not endorsing or unendorsing any leader or candidate or party. I'm equally despondent about all of them. I look in the United States right now, and I would say there is a stronger civil libertarianism than I for a very long time. And I spent part of my training in the United States and have great memories of it and many colleagues within it. But you know, the mindset that says there are no rules that apply to me is in direct opposition to the concept of public health and the well-being of populations. And frankly, I think we have a philosophical and political discourse to be described as to when will the good of the many and in what circumstances the good of the many outweigh my individualism. South of the border, we see that played out in a discussion about constitutional rights. North of the border, we're increasingly seeing that played out in terms of what group do I identify myself as part of, and to whom or who does that group have accountability and responsibility. So I think we are very much in a counter wave of this.
Yeah. If you look around the world, there's various studies. The very high individualistic countries have been on a proportional basis suffering the worst problems. The more group or oriented countries, and I'll use the Scandinavians as an example, but even South Korea, although maybe a little more authoritarian, have coped with this much better. So that feeds in.
And how normal, right? I think norms are stretched very differently in Canada today than they were a generation ago.
Absolutely. I'm going to go to some of the chats. Okay, so somebody's trying to fix your phone. That's okay. So I'll keep going to some of the others. One of the other things that we talked about was as you come out of it, and you mentioned that there may be a recurrence, we should certainly, if not plan for it, have a contingency plan for that. How hopeful are you that we will actually have vaccines, and more importantly, actually have that kind of behavior change that you're talking about? Will it sustain?
Yeah.
Right now, it's good for us to all say yes, because we all think Trinity Bellwoods was a bunch of nutcases. But are we going to say that in 18 months' time?
Well, I think so. I'm always of the mindset in healthcare: prepare for the worst and hope for the best. So I'm going to assume that there is not a rapid vaccine developed. Coronaviruses have not historically seen rapid vaccines or any vaccines developed. And for life-threatening illnesses that are perhaps less easily passed along than this one, HIV would be an example in the generation past, where we still don't have a vaccine. It's become a chronic disease, and we've greatly advanced the care of clients with HIV. But you know what? We didn't find a vaccine, and I think one has to consider, in the absence of a vaccine for this coronavirus and others that are equally difficult to discover one for, then what are the alternatives? And they may be better understanding the creation of antibody testing, better understanding how to build immunity to the illness, if not through vaccination. And post-COVID illness, how long does one have a serum response that prevents you from being reinfected? So if all of the colleagues on the line today in your workplace could say, look, there's probably 30% of people who at the moment have a seroprevalence that protects them from getting COVID for 3 to 6 months, are those the colleagues that you'd say they should be the first wave of people back to work? Would say yes, that's a reasonable approach. On the changing behavior, I'm going to put myself down as doubtful. Again, I don't think we're going to become less libertarian-minded or less individualistic. I think we are drifting into that world of, and this does worry me, of pseudoscience, of non-science, and nobody can tell me what to do. I have autonomy. And you know what, that can be enriching and remarkable in some spheres of life. And when it comes to public health and prevention and disease management and control, disastrous, as we saw well before COVID with anti-vaccination advocates, who again, no science to back up the claims, but you know, many well-known popular people who were advocating this, and again, pseudoscience. So, and I'm not suggesting science is the only answer. Right?
And the weight of evidence was so strong, but it didn't get out there with these people. I'm going to a couple of, if we can go over a little bit over the half hour, a couple of questions. Linda Weaver, for years, private sector companies have been asked to participate in healthcare policies and decisions, but have been told this is the job of government and health organizations. Most companies recognize employee health as important, but have not been welcomed into the discussions. How can this change on both sides?
So I think more enlightened groups will help us understand that while, in my opinion, the concept of universal access is not that it needs to be necessarily everything publicly delivered or publicly managed, but universally accessible. So I think there are many great examples, including in our own Canadian system, where private services are delivered well: dentistry, optometry, physiotherapy. There's lots of parts of the Canadian healthcare system that are already private, yet many people don't think about them because they're done mostly through your benefit program. I think increasingly we will have to look at, and I think virtual care may keep the door open on this one, where there is no terrestrial boundary. It doesn't really matter if you want to see the best person in the world for your child's unfortunately recently diagnosed leukemia. Do I really need to stay in Toronto? Or if the best person in the world's at Hopkins, can I do a virtual visit and can I actually get the very best care? And am I willing to pay for that? And of course, the ever active dynamic of not being a nation that wants to say that those less economically advantaged should be more advantaged when it comes to healthcare delivery, I think remains very present in our political landscape. But what I do believe is that more comfort with private providers was coming. I actually, this pandemic has set us back very dramatically. And it set us back dramatically because of what I believe, and I don't have the data to confirm this yet, there has been a correlation between long-term care homes that have had very bad outcomes and being for-profit enterprises. I think there's a danger of jumping, and we're already seeing this in much media and some advertising, that ergo private sector long-term care delivery is for profit and they do bad things to patients, and alternative forms publicly delivered are good. I don't know that that's true or not true. I know it's correlated at the moment to about 70%. And if that's true, we need to move from correlation to understanding causative factors. There are other correlates of that. I looked at some of the data and it shows that about 70% of those homes are what we would call category C, old beds that need to be repurposed. They're small, they share washrooms, they're cramped, the distances aren't as great, the access to outdoor air environments are smaller. So they're basically old buildings. And one would actually expect worse infection control measures in old buildings with cramped quarters. But I do actually think that may well challenge the private sector in the public health care for the short term.
Good. A couple of last questions before we go. From David Weiss. How has UHN modified its people practices as a result of COVID, and what will be different when the restrictions are lifted?
Yeah, so I think 3 or 4 things at a minimum. One, so many more of our colleagues have been working effectively from home. And I see no reason for us not to continue to explore that, if not full in part. UHN is on expensive land in downtown Toronto. We are growing rapidly. We have inadequate space. Our expenses are very significant. And you know what? I think the reality is that many people would actually like to do or like to work a portion of their time at home. Secondly, I think we're going to be much more oriented to virtual care.
Yep.
And you know, we've heard from our clients for a long time, don't make me come to downtown Toronto for simply the results of a blood test. Thirdly, I hope that the fee schedule, the way that physicians in this province are paid, continues to allow us to use technology in a way that's of mutual benefit to the provider and the consumer. So that's an if, but I think if that occurs, that we're recognizing that the traditional fee-for-service model of laying your hands on a single patient at a time in a single physical place is an antiquated model, that cyber infrastructure is just as important as physical infrastructure. And last but not least, I would say the people who make up our enterprise will change. And in part, that will be the kind of data scientists and experts in algorithms and an increasing number of people involved in large data and artificial intelligence, machine learning, that more and more and more those disciplines need to be included in the health sciences. They are, for the majority of our chronically ill patients, those things which will make a difference. And part of that, I think, is also much shorter lengths of stay, that people don't wish to stay in hospital. If you're not acutely ill, it's not a very good or safe place to stay. And if we can convert a whole lot of things from inpatient procedures to day procedures, it just may allow us, the economic models, to catch up on some of that work that we've now dramatically fallen behind on.
You've just done a wonderful summary of the 2 points, so thank you for that. I'm going to hand back to Robert with great thanks to you in just a second. And obviously UHN is in great hands, so like the healthcare system of the country, so thank you. Robert, let's go back to you to do the wrap up.
Thank you very much. Please join us at our next fireside chat with Walmart's Senior Vice President John Bayliss on June 4th at 11 a.m. That's 1 week from today. John leads Walmart's logistics and supply chain and will talk about the challenges in ensuring the shelves are stocked across Canada at both retail stores and Walmart online during COVID-19. To sign up for the Walmart Fireside Chat and others, please check the chat function at the bottom of your screen, and you can register online for that. Again, my thanks for everyone attending today's session, and a special thank you to Dr. Kevin Smith and to Alan Middleton. Have a great afternoon, everyone. Thank you.
Thank you, Kevin.
Thank you very much. My pleasure. Bye for now.
Take care.